Welcome to the Beyond Pain podcast with your host, Joe Gambino and Joe LaVacca. Join the two Joes, two physical therapists, as they discuss how to navigate the uncertainties of pain so you can move beyond it and get back to the activities you love most. This podcast is for Joe, and their guests to share their clinical thoughts and ideas based on their collective clinical experiences. Can this information be for you? Maybe, but we cannot know for sure. Therefore, it is always worth talking to your healthcare provider to make the best decisions in your care before you implement anything on this podcast. And please use common sense.
Welcome back into the Beyond Pain podcast. I am one half of this show, Joe Gambino, and Mr. Joe LaVacca over there, Dr. Joe LaVacca over there is the other half of the show. This podcast you can find on YouTube, Cups of Joe _PT, on Instagram, Beyond Pain Podcast, and we are most active on Instagram, LaVacca over there, at Strength and Motion _PT, and myself at Joe Gambino DPT. And if you do want to work with us, you can find an application form in the show notes. Feel free to fill that out, and one of us will get back to you. Welcome back, my friend.
Good to be back. I'm excited to continue our knee pain conversation, especially with some of the things that we brought up in our previous episodes. So for those listening, if you did not check out our previous episode on anterior knee pain, go back, click on that, listen for some context, because I think what we're going to be spending most of our time on today is just maybe trying to delineate a little bit more about all these anterior knee pain signs and symptoms. And well, hey, you guys spoke about patellofemoral pain and meniscus pain and this type of pain. How do I know I have that? So I'll run you through some lists. We'll run you through some ideas that we always do and help maybe clarify some treatments or ideas or just set expectations for you and your providers, because I really think that that's an important part of the process.
Yeah, I like this topic because I really wanted to make it where if you're hearing some of these things that you should have like, okay, maybe this is what's going on if it sounds like you. Because just a quick aside, because, like in clinic talk in a sense, but when we were at PT school and when I had students, when I was at Perfect Stride, the number one thing that people say is that the stuff that you learn in school is not the stuff that makes you a good practitioner, right? But then I sit here and I'm like, well, probably the thing that you learn from PT school that is probably the most important thing is the typical signs and symptoms for any sort of diagnosis that's out there. The age range, how it occurs, whatever it is, right? Because then when you started to talk to somebody and then all of a sudden you're like, well, they fit this age group. They are, sometimes it's male or female, right? That's more prone to something. The story starts to tell you that it's like, oh, well, all of a sudden now I can start to think, oh yeah, you may have a meniscus tear. And now when I assess you, I can confirm that or dispute that. And then I can start to do, we'll talk about, what differential diagnosis is as far as, is there other stuff that can kind of mimic this, that it might actually be a set of maybe a meniscus or something like that, and how we can kind of figure out, is it this tissue versus that tissue? So I think this is a great topic because even if you're not a provider and you're listening to this and hope to have some answers for your knee pain, if you start to see these stories line up with you, then you might be able to say, okay, I might have this, and then you can go get it looked at by somebody to confirm or deny it, right?
That's right.
So you can, if you have thoughts, you're more than welcome to do that. But I don't know if there's some place specific that you are looking to start as far as this conversation goes.
Yeah, no, I think the most important thing is having a good conversation with your provider. And in a busy clinic, when time is of the essence, or potentially even lack of confidence of your provider is a factor, depending on how long they've been in the field, I think it's really worth noting that your history, along with the likelihood of the diagnosis. So let's just start with patellofemoral pain, right? So patellofemoral pain on average is going to affect maybe like 20% of the population. So it's a pretty high number, but it's probably not going to account for every bit of anterior knee pain we see. The thing that we mentioned briefly in the previous episode is that a lot of these cases, though, don't resolve in 6 to 8 weeks. I know more than half linger for months at a time. So it is really important that you and your provider have those conversations. They understand your history, because with the special tests that you and I can do, whether it's virtual or in person, and I was reading a lot about special tests this week, 2/3 are weak or have unknown value in terms of them giving a diagnosis. So if you have been a PT patient, your PT might have like wiggled your knee a little bit, twisted it, done some sort of slide or glide. And these are all called special tests that are helpful for ruling in or ruling out a diagnosis. But the only way they really work is by understanding the prevalence of what we're trying to rule in or out and your history coupled with it. So from a patellofemoral pain standpoint, that's where I'm going to always be asking people activity levels. Did we jump up too much too soon? However, it is also kind of correlated with a lot of just sedentary populations too. They'll start to tell me how they have what we would say is a moviegoer sign. Hey, I might sit down for 20, 30 minutes. My knee really aches. I have to get up, move around. People who commute a lot or fly a lot in New York City, that's another sort of like big one. Maybe there will be some mild swelling, but it'll be around the knee joint complex, not maybe like interdispersed around the joint line, at least from my experience with it. And then typically we might find a little bit of limitation where that kneecap doesn't move around. It is called a floating joint. So it should be that you take your kneecap and you can move it along the face of a clock, 12, 6, 9, 3, big circles. And if it's moving freely, great. We know we have good mobility there. But those would be kind of like right off the bat, like sort of things. Sensitivity to load, sensitivity with more anterior load. And I think you pointed that out for our listeners in the last episode. But when that knee goes more and more over the toe, maybe when we drop a little bit more into flexion or bending of the knee, that's going to become more sensitive. And then I kind of pair that with the quote unquote moviegoer sign, which is usually, a nice way to kind of rule in or out patellofemoral pain. You got yourself muted.
Well, yeah, my little colorful mic here. If you're on YouTube, I look over here and I wasn't muted. So anyway, I agree with that. I think that was well said. The one other thing, like this, if we're ruling out, right, is that anterior load stuff, right? Like if I can alter positions and all of a sudden it feels better, right? Then all of a sudden I'm like, okay, yeah, this is all, Again, I think I think it's also easier to rule things out if I remember correctly, like than to rule something in. My goal is to just kind of like rule things out as quickly as possible and then kind of move on. But again, I always go back to movement, what's painful, what's not painful, where, like the assessment, right? Movement diagnosis over a particular diagnosis really kind of resonates in my head. But if I hear all these things, I'm definitely going to be starting to think about the patella joint and everything else that's kind of going on there. And I'm going to just let you keep running with this. You can go right into meniscus since you're doing such a great job.
Well, man, I appreciate that. Meniscus, just my mindset shifts a little bit.
There's your compliment.
I knew it was coming, man. I knew it was coming. Meniscus, I think this is where age comes into factor for me, as well as mechanism. So with age, we'll start with older than 40. And that's not to hurt anybody's feelings. I will be approaching 40, as will Joe, in the next year and a half. So we know what the struggle feels like. But if you're over 40 without a specific mechanism of injury, and you're maybe getting some locking or catching around the joint, maybe we have some loss of range of motion, particularly in extension and end range flexion. So usually moving the knee in those middle ranges feels pretty good. And then when we try to lock out the knee, it kind of hurts if it's more maybe anteriorly involved or like on the front side. And as we start to, push the knee backwards, if you get that end range pain bending the knee, maybe it's more of a posterior side implication around the joint. But if you're younger, and let's just kind of throw younger into this category of less than 40, then you might, not all the time, you might have a mechanism that involved some sort of pivot and shift, that involved a contact. Someone may be rolled up on you in your sport. Maybe you fell. So if you're younger, the mechanism is going to really ring true and then probably help me rule out that patellofemoral pain idea, because there was a specific moment in time, not a gradual buildup. It's going to probably take away tendonitis for me, right? Because you had a mechanism, right? The tendon of the knee, like we said, is mostly going to get irritated with repetitive loads, particularly with jumping. And then it's going to bring me to, hey, well, what's left? I mean, really the big picture stuff, looking at the joint itself, the integrity of it itself, and then to couple old and young together, I would typically look for swelling after activity. And that's going to be another hallmark, in my opinion, of these meniscal type injuries. So you can feel good. Hey, knee's looking good. I go on a bike ride, I go and run, I go to the gym. I was fine the whole time. And then 6, 12, 24 hours later, I look down, knee feels really icky. I lost some motion. It maybe is a little warm, but there's definitely signs of swelling. And then that's your sign to say, whatever you did in the gym, even though it did not hurt, might be a good time to pull.
Yeah, I like that breakdown. And maybe here's a question for you that I think might be on a listener's minds, because meniscus is one of those things that's very, very common to go under the knife for. So at what point in time would you say these are the findings that pop up that maybe we should consider that as an option?
I think the biggest thing, from my understanding, is this swelling response. So if you have a mechanism, particularly, right, like you fell, you got twisted, you got rolled up on, and you're having a lot of swelling, then you might be one of those people that responds to surgery early on. And maybe that swelling is just a sign that there was a little bit more involvement of the joint tissues, the cartilage, the meniscus, you name it. Maybe that tear is kind of quote unquote, more complex than some simple tears, quote unquote. But when we just look at the idea of like, well, I got an MRI, I have this tear. Well, the outcomes kind of fall apart. Just because your tear might be a little bit bigger or more complicated doesn't necessarily mean you fit the bill for surgery. Just because your pain's been around for a little bit longer doesn't mean you necessarily fit the bill for surgery. And the cool thing about a lot of those meniscal surgeries is when we compare them to placebos, meaning you fall asleep, they drill, not drill, but they cut kind of 2 holes into your knee. And then they basically look around with the camera and then sew you back up, versus putting 2 holes in your knee, looking around with the camera, doing the debridement, doing the cleanup, doing the repair, doing whatever they need to do. Well, just the look around surgery and the real surgery a year later have very similar outcomes. So does that mean that surgery does not work? No, I don't want people to leave with that message that, oh, well, then why would I ever get surgery? Surgery is a very personal decision. So if you have a knee injury and you have a lot of this swelling, and you and me and all the PTs out there are like, no, don't get surgery. We know it's no better than placebo. But now you're talking to a single dad or a single mom or someone who works 3, 4 jobs, or someone who just doesn't have the time, doesn't have the motivation, doesn't have the desire to do a rehab program, then surgery is perfect for that person. They don't need to live in agony. They don't need to live with constant catching or locking of their knee if they are not going to be able to commit to a rehab process. So I think that's what I would look for. Swelling, number one. The mechanical symptoms even are a little bit inconsistent, because I used to guide people on, if you're getting catching, locking, instability, you should probably consider the surgery. But now I'm really more about the swelling response, your mechanism, and what's your life going to look like as you commit to a process of healing and recovery.
Yeah, I like that. The other thing I would add is, activity level. If you're playing college sports, you're whatever, you just enjoy being active, and this is going to slow you down for a period of time. Something, again, right, I do think it's a very personal decision. I always tell people you have to weigh the risk reward of anything that you do, right? I mean, I'm always someone who's going to say, if it was my body, I'm going to try to delay anything as long as possible. If it was a huge impediment to my life and I knew that I can, potentially feel better sooner with the surgery or something like that, then it's something that I'd have to consider, right, and weigh my options. So I think that you should always consider, and if you're someone who's adamant about not getting surgery and you do get a doctor says you should get a second opinion, right? You should weigh all of your options and figure out what is the best thing for you, right? That's really all I have to say on that. I think we did a pretty good job there as far as these 2 symptoms go, or diagnoses go, as far as what you would feel there, when you should look for surgery, things within that nature. Is there anything else that you'd like to add or bring up here? I know this was a little
I think,
here.
Again, that's a lot of information in a pretty short period of time when it comes to assessment or even things to look at for yourself. So I would just encourage people, if you have more questions around your condition, that's a perfect time to fill out that form. Send us a DM on Instagram or comment on YouTube, and we can maybe add a little bit more context to your case, work with you, help you out, and hopefully get you back on the path to recovery.
Yeah. And the last thing I'll say here before you can take us home is, again, with all these diagnoses, they're diagnoses, right? They're not labels. They're not a death sentence. You have a meniscus tear. Many, many people do very, very well. Conservative care, surgery, get back to everything they want. Same thing with patellofemoral pain. Same thing with a lot of diagnoses out there. So just because you fit into one doesn't mean that you're destined for lifelong pain or anything like that. You just need to find the right approach, or you just kind of need to go about finding ways to work on that in a way that suits you.
Absolutely, man. All right. Well, Joe, thank you. I love you. Let's do the thing. I feel like I just don't
You do
it
a great
right.
job.
I'm not
That's
sure.
just like a heart. Yeah.
Okay. Yeah. All right. I'm kind of getting better. I feel like I turn too much. I just have to keep it straight on for those watching on YouTube. My hearts are getting better. Anyway, Joe, thank you. We love you. Listeners, we love you. Thank you for making it this far into the episode. And don't forget to tune in next week for another episode of the Beyond Pain podcast.